So my name is Mary Fleming and I am the Interim Chief Exec at Wrightington, Wigan and Lee, and I'm so grateful to Seika for inviting me here. I find them so interesting, these events. This is a really important bit of the day, particularly because we've got the people that are absolutely crucial to the patient's journey and absolutely a key part of the multidisciplinary team. So I'm really keen to hear from the ladies on my left-hand side. But we're going to start with Seika, aren't we, on the importance of technology in colorectal surgery.
Thanks.
So I am keeping you to time. So
yeah. No, I'll finish before time. Thank you. Okay. Thanks, everyone. First of all, thanks for coming over. It's been a fantastic day so far. Thanks, Rachel, who has managed to bring everyone together and helping or sort of leading the putting the program together with the rest of the team. As surgeons, we like our technology. And so we start off with looking at robotics in colorectal surgery. When I started my surgical training, I still remember I started in Doncaster as an orthopedic trainee here. And when there was a spinal surgery which was going on, and the surgeon made a big cut about 10 centimeters long. Then I looked at him and he said, "Don't look at me like that. About 5 years ago, I used to make a longer incision." Big surgeons, big incision, and that is what used to be. But nowadays, if you can get away with a smaller incision, then that is preferably better, and that is where the technology comes in. So what we used to do with a big incision on the left-hand side, nowadays we can do it with these minimal access technology. So that is what the advancement in surgery is, and what we do inside the abdomen, removing the organs, rectal cancer or colonic cancer, the principles are the same as what was about 50, 60 years ago. When we look at open and laparoscopic rectal cancer surgery, rectal cancer is technically challenging for the surgeons. And when we look at the trials, comparing open and laparoscopic surgery, there are 4 major trials. As people who believe in evidence, we believe in randomized controlled trials. And there are Korean trial, COLOR2, ASACOG, and a la carte. They're all from the different parts of the world. They showed basically that it is safe and feasible to do. And some of them showed that there was insufficient evidence, basically, depending upon what the primary endpoints are. But the bottom line with these 4 trials is they showed that in the short term, it improved the outcomes because the length of the incision is reduced to a smaller cut compared to what we used to do with an open operation. But there are limitations with the laparoscopy. It has got a steep learning curve. The instruments are fixed. It's like chopstick surgery. It is called chopstick surgery because when you move the instrument to the left, it is counterintuitive. What happens inside is you move the instrument to the right. You get a 2-dimensional view, whereas the organs, when you open the patient up, you get a 3-dimensional view. And exposure and retraction are challenging. When you look at rectum, which is deep down in the pelvis, especially in people in the Northwest where there's a high BMI, it is very difficult to do these operations, and exposure is difficult, retraction is difficult, and then also if you want to divide the bowel below the tumor, it is technically challenging. So this is where, and also 1/3 of surgeons suffer from repetitive strain injury using a laparoscope because you're in a fixed position, ergonomically not sound, and you get these strain injuries in your hands and wrists. So this is where the robot comes in. It's ergonomically very sound. It has got 3 components, at least the current models what we have. There's a patient cart, which is one on the left, which docks to the patient. And there's a vision cart where we see, or at least the rest of the team sees what is going on. And there's a surgeon console, which is on the right, where the surgeon sits comfortably in an ergonomic position and operates so that hopefully there's a less risk of repetitive strain injury. And when you have a comfortable surgeon doing an operation in a magnified view, then you would hope that the outcomes would be better. And also there are sort of 4 arms, like you can see on the photo on the left, which attaches to the patient. There are 4 arms, which means that one of the arms is there's one for the camera, and then 3 arms which are under the control of the surgeons, so which can be used for providing fixed tractions. And also the instruments are endorest, which means like you don't open the patient up, but you do like having an open operation, like articulated instruments. And you get a 3D view, which is magnified. It is usually helpful when you're trying to suture, stitch something inside the abdomen, which is difficult when you do a laparoscopic surgery. And certainly it is shown that the training is short, and we have seen in urologists who did open operations, who did not do laparoscopic surgery, but have taken up robotics in a big way, and that is where the biggest evidence is, basically using for the prostate, where most of the prostates nowadays in the country or throughout the world is done using a robot. So evolution, when we look at how the technology evolved, in 1999, the first system came up, and then in 2006, there was only one provider till about a couple of years back, which was Intuitive Surgical, and they produced the Da Vinci system, which the second version was in 2006, and it had a bit more technological advancement. And we have had at the Christie since 2007, initially used for the urologists, for the prostate, and then the gynae and the colorectal started in 2012. And then we had the 2009 version, which is the SI system, which had a bit more technological advances. And the latest one is the XI system, which is really fantastic, because one of the problems with the previous versions was you could operate on one quadrant of the abdomen, especially if you're looking at the pelvis, you operate on the pelvis, you can't look at. If you want to operate on the upper abdomen, you have to redock, which meant that there's a prolonged operating time. Whereas with the newer system, with the XI, you can do everything in one sitting, one docking, and the view is fantastic, and it has got additional technological advances. So just to get the facts right, robotics in colonic surgery, right colon, left colon, and an extended right hemicolectomy. Currently, I would say that it is used as a training tool, because for the robot to be used, it is not an individual surgeon's skill which is needed, it's a whole team which needs to work. And it is used mostly as a training tool to get this system embedded in the hospital where robotics is introduced. So I would say that basically there's not much of an evidence in colonic surgery, apart from when we are looking at doing a bit more a detailed dissection of the superior mesenteric vessels, and then clearing the lymph nodes very proximally. So there is only a limited role, or possibly no role, and the cost is not justifiable, at least in the current climate. So then looking at the rectal cancer, which is where the evidence is, there's the trial called the ROLLER trial, which was led by David Jane in Leeds, which showed that there was a conversion rate was less if you're using a robot to do an operation. And then in the subgroup analysis, there was evidence that in men who have a low anterior section, who are obese, there is evidence that it improved outcome, but it was not statistically significant, although the 30-day outcome, post-operative outcome, and morbidity was less in the robotic arm. So at the Christie, when we look at our experience, we started in 2012. Probably I would say that we were one of the first hospitals in the Northwest. Now I know James and Claire do it at Salford, and Wythenshawe has got a robot. So the systems are coming in. Initially, we started as a hybrid procedure, because when we introduce a new technology, we don't want to start off doing a long operation, because it has got its own problems. And that is one of the problems with laparoscopy, when it started with the patient being head down for a long time. Some of them developed cerebral edema, was intubated overnight, and there were issues with that. So we avoided that by using a hybrid technique, which meant the colonic part of the operation was done laparoscopically, because we were used to that. And then the robot, where the benefit is in the pelvis, preserving the nerves, so we started doing that. And then moved on to completely a robotic procedure, which is what we've been doing for the last 6-7 years. So we do, because of the case mix what we rarely get a standard straightforward anterior resections or APRs. We get all those patients who Claire and Mike have had a go with neoadjuvant treatment, and basically sort of it is unpicking the rectum from the pelvis, because it's all stuck. It is sort of it is difficult, but then that is what we are. That is the service we provide at a tertiary center. So when we looked at the outcomes, length of stay, the pathological outcomes, reoperation, conversion, and mortality, but and also the operations. What we do are anterior resections, APR, and excentrations. We've done posterior excentrations, and also we've done a total pelvic excentrations. So these are the standard positions which we use for the ports this is for the third version of the robot, which we now don't use it. So what I'm trying to get at is with each of these versions, it is like the newer version of the car. Basically, with the clinical feedback, they improve the technology. So it is like driving a car. It becomes what was a manual sort of a docking, now it's an automatic docking, so it's like an automatic car. So that is how the technology has evolved with time. And most of the patients who are referred to the Christie have got a stoma already because before their chemoradiation, the local hospitals, because of obstruction, for whatever reason, have given them a temporary. So we have to change the port position based on those needs. And with the newer version, it is a bit more different alignment we use. And this is just, I don't know whether this video is going to play. This anterior rectum is one of those difficult parts of the operation. When you do open, surgeons will say that they can see it, but you rarely see it. You put your finger and then do this bit of a movement, and then you find that it's released from the. Whereas with a laparoscopy, you see a bit. With a robot, you see clearly what is going on, and you have an articulated instrument. So you can see things much more magnified, and you can do a more precision surgery. One of the things we have done at the Christie is those patients who need a TPC, total pelvic excentrations, if the tumor is just involving the seminal vesicles, then we can avoid giving them 2 stomas, basically working jointly with the urologist. We do a lot of joint operating, and to an extent that we have them as a part of a job plan. We are supposed to cover each other's specialties. So in this patient where the tumor was attached to the seminal vesicle, with the urologist, we removed it so that the bladder and the prostate is preserved, so the patient ends up with only 1 stoma. So this is a specimen, posterior exentration, which means the uterus, rectum, and the posterior vaginal wall has been removed, which would have been done with an open operation, which we can do it. We have done about 18 procedures of this sort. Not everyone is suitable. They all go through the MDT, and then we discuss with the other specialties, and then suitable ones we offer these minimally invasive technique. So 112 procedures, it's not a big number. Because ours is a very sort of complex cancers which gets referred, only suitable ones go through these minimal access techniques. And when we look at the numbers, these are the numbers. We have done 17 posterior clearances, and there's a lot of stomas we give. One of the main reasons why we give these stomas is functionally what we have realized when we did these resections and did anastomosis initially. The functional outcome was not good because they have had long course chemoradiation. And especially what we notice is after radiotherapy, the longer you delay, it is not a delay as such because the patients go to their local MDT and then come to our MDT, and then by the time it's about over 12 weeks, and when you operate, the function is not great. So it is better to do 1 operation and you get these patients, and most of them seem to be okay with that. And when we look at our R1 resection rate, which is one of the markers of long-term local recurrence, is much less, and the complications are less. We have not had a 90-day mortality, and we have had 2 patients who had to be reoperated, mainly for the stoma complications. So in summary, I think most of our patients, 3/4 of our patients are T3, T4, 83% had a threatened margin, and they've all had neoadjuvant chemoradiotherapy of some sort, and then the conversion rate is very low. And this is the sort of figures which we have maintained over the last few years. So in summary, robotic rectal surgery is used for standard and for complex resections with a low morbidity and mortality. And what is coming out with the new technology is just to check that. And one of the problems with colorectal surgery is anastomotic leak. If a patient develops an anastomotic leak in a lower rectum, it is a bad outcome. They either sort of, you can lose them, or if you salvage the anastomosis, functionally it is not great because it does not have the compliance to expand. And one of the ways we can address that, or to some extent, is using a fluorescence to check whether the blood supply is good, and this is possible. It is possible laparoscopically, but robotically it makes it a bit more easy because you give an ICG and then switch a button, and then you can get the green light to check for the fluorescence. So we have a GMCA guidelines, which came out in 2017. I think we were the only place who were doing it at that time. There was no clinical evidence in colonic cancer, selective use in rectal cancer, low rectal cancer in male, locally advanced. Obviously, the economics was challenging, but with more systems coming in, more competition coming in, the prices will certainly go down. At the moment, it is about 1.5 million to get a robot. And the hardware, the machines are improving with time, especially with the newer XI system. The camera setup is fantastic, and it makes the job of the surgical team much easier when we do these operations. And most of these trials are non-inferiority trials, which is not surprising because what we do inside the patient is the same whether it is open, laparoscopic, or robotic. Although it can be tailored to some extent, depending upon, with time, we may be able to do a less radical operation. But at the moment, we follow the same as what is done in the what we used to do with any standard resections. And these are novel technologies, and the communication is very important because the surgeon, as you can see, sits in a separate console, and the team, you have an assistant. Most of us rely on extended surgical team with the surgical care practitioners or the surgical first assistants, and sometimes if they are not there, it makes it extremely difficult to run these operations because the whole team is a different person every time, makes it difficult, whereas having these extended roles makes a big difference. So the benefits are, I would say it's more precise. It's a tailored surgery. You can see the nerves, you can preserve them, and that is what has been shown in the prostate, and that's what we are trying to see whether it makes a difference in rectal cancer, although these patients have had long-course chemoradiation, so it's not that great as an evidence, and wound-related complications are less. There is some evidence that there's a greater lymph node yield, and the R1 resection rate is less. So in conclusion, because you see better, you have an articulated instruments, you reduce the collateral damage, and it is certainly good for training. One of the problems what happened with laparoscopy when it came in was the consultants were getting trained, which meant that the trainees were not getting an opportunity to get trained. Whereas nowadays, these with the robotic simulators, they can practice it in their local hospital. They don't need to come to any specialist hospital to get their hands on the number of hours what they need initially to get through the learning curve. So it is possible for multi-specialty operations. It may reduce the need for stoma, and the benefit so far is only marginal. So that's the end of it. Thank you very much.
Thank you, Serka. I thought that was a really pragmatic and balanced view, actually, to the role of particularly robotics in colorectal surgery. But don't disappear, you're on the panel. So sticking with the theme of teams, I'd like to invite Amanda and Cheryl up, please, to the podium to talk about the very important role of the clinical nurse specialist.
Oh, okay. Thank you. Okay. Oh, thank you for saving the best till last. Cheryl and I are here today, along with the other team, to celebrate really the role of the CNS and the extended team. I just want to start off with the evolution of the colorectal specialist nurse. This developed over 30 years ago, and a few of us within Salford Royal were quite privy to know a very special colleague who developed the service, a colorectal specialist nursing service in Salford Royal, what used to be called Hope Hospital, over 30 years ago. And this lady was called Stephanie Hughes. Some people may know her. She used to work with Nigel Scott, and they developed this fantastic service. And without her, actually, I wouldn't be here today. I can get quite emotional about that because she'd made quite an impact on my career. So, as I say, she developed the role, and as a junior nurse on the ward, she would be always on the ward, seeing our patients, supporting our patients. What she didn't know about colorectal diseases was not worth knowing. And she was why I came along to do my job. So I've got over 20 years' experience as a colorectal specialist nurse, starting off at Salford Royal. And firstly, I came into the team as a stoma nurse, and then went on to be a colorectal specialist nurse. And I was there for many years looking at both patients with colorectal cancer and benign diseases. And then years went by, I grew, developed, and then obviously went over to Christie's where I am at the moment. But what I can actually say about the role of the CNS, no matter how long it has been going on, the main reason why we do our job is to support our patients at the end of the day. Our patients are paramount to what we do. And I do think without the CNSs, I don't think people within this room would be able to do their job as well as they can do as well. That's me being biased, but I would imagine that all the CNSs and the extended team would support me in that. I have gone off piece. Cheryl and I put these slides together, but I thought I'd just speak from the heart. And there's a lot of things today what's actually resonated with me and what is really important. So, yes, we can... Oh, I need to click. Oh. Bear with me. So if you can see there, that's what being a CNS is. And yes, it's really important that we're translating important information to our patients. Patients are diagnosed with colorectal cancer. It's really difficult for our patients to deal with this, both physically and psychologically, and we are the linchpin, what holds everything together for these patients. And moving forward actually so looking back 30 years, moving forward to kind of 15 years on, that's when the multidisciplinary team kind of developed. And I and many of my colleagues here today were part of developing that. And this was a really pivotal role for us as CNSs to be the advocate for our patients and get that voice across. So that was kind of late 1990s, early 20s. And then moving forward to currently, I have decided just to talk a little bit about the inequalities, what we saw today at the beginning of the talk. And that has really had a big impact on myself because I think that is the future of colorectal specialist nurses. I know we talk about health and well-being and improving quality for our patients, but I think we need to kind of also move forward and incorporate a lot more of this into our day-to-day practice. So as you can see here, we are pivotal to what we do with our patients. I'm quite passionate about what I do. I wouldn't have been in the job for over 20 years. If I weren't, I would have moved to a different career. This is a career pathway. However, it's a passion also as well. I'm going to let Cheryl take over now. There we go.
Thank you. I'm Cheryl. I'm a colorectal CNS at Salford. So for me, as being a CNS, it's there from diagnosis to treatment and through follow-ups. We do a 5-year follow-up across GM, and we provide that as colorectal nurses at Salford. I do find it a very rewarding role, supporting patients, also their families and carers. I've accidentally missed off the rest of the MDT, but obviously everyone's together working for the patient, and supporting patients throughout their care. So we meet patients initially, probably in endoscopy, might be the first person to say, you might have a bowel cancer, and then we phone them after MDT to give them updated information, meet them in clinic with the consultants, see them on the ward and provide the follow-up. So for those patients, like Claire said before, this young lady here, the patient really remembers who you are, which is, it's really warming to know that. And we are that point of contact. Our phone number is given to patients to ring if they need any advice or support. Colleagues on the ward, junior staff, we give our contact details. I'm representing colorectal nurses across Greater Manchester. Myself, Amanda and Sarah are the lead CNSs for GM Cancer, and it's sitting on the pathway board and being there to take our point forward for our patients and for us as CNSs within Greater Manchester. And in terms of future education, like Amanda touched upon before, people have multiple years of experience doing this job, and it's not always something that you can kind of hold a certificate up and say, I've been a CNS for X amount of years. It's how do we kind of imprint that for the future for people coming forward. So with the GM, Greater Manchester Cancer Academy, Jess Dox is in the room, she's been giving out the information. There is a colorectal specific work force on there, so lots of information is going to be shared on there. The Ascend framework, nationally working for clinical nurse specialists, is bringing things together, what we do within our role and how we can improve services. So it's just a tiny bit of what we do, and not just the colorectal CNSs, but other team members that have come to speak as well today. So we've got the cancer care coordinators as well. We did put some information together, just a sample of kind of experience across Greater Manchester. So in Salford, where I work, we worked with an average kind of length of service. So we've got 3 CNSs with 15 plus years experience, and then 4 with kind of 6 to 13 years experience. And then at Bury, Rochdale and Oldham, we've got the 30 years experience across a team of 8. At Christie's, like Amanda said, she worked at Salford before. They've got 51 years experience across that team. MFT, they've got average length of time in post of 9 years, and 3 CNSs with 14 to 15 years experience, and 3 with 3 to 5 years experience. So it's seeing that in some of these post, people are probably heading towards the end of their career, and how are we going to implement the future CNSs and bringing that forward and encouraging people that it is a very rewarding job to do in a tough climate, but it is rewarding and we do enjoy our roles. I'm going to hand over now to these lovely ladies, the cancer care coordinators, who are going to give you some more information.
Hi everyone, I'm Melissa.
And I'm Becky.
We're the cancer care coordinators at Wythenshawe Hospital, and we work alongside the CNSs.
So the main focus of our role is to develop personalised care and support plans. So we do that by completing holistic needs assessments with the patients, which are just conversations really that we have with the patients to identify what support that they might need. There are main categories of support that we identify, so that's physical, practical, emotional, spiritual, like support with their family and relationships, and also like information needs they have. We offer them face-to-face or over the phone. It's always about like what's more comfortable for the patient.
And once we've had the concerns that have been identified, we then refer and signpost to community. An example of that is being there, or like in the trust, which is the welfare rights team. Another part of our role is to help with coordinating end of treatment summaries. We make sure that they're sent out to the patients and the GPs.
And we're also involved in organising health and wellbeing events as well. So these are just events, they provide information to patients. So we get a vast team of people together. So there's consultants there, nurses, dietitians, different charities, just so the patients can access all this information. And it also gives them an opportunity to talk to other patients that are going through a similar thing. We've got our first health and wellbeing event that we've not done one since before COVID, and we've got one coming up in 2 weeks' time. And it's a face-to-face one, a group one, with us and 2 other trusts.
Within the team, I'm responsible for the personalised stratified follow-up, so that means that I'm their primary contact for that type of patients. Personalised stratified follow-up is a way of following a patient up depending on their needs. So that basically means the people that are well, they can focus on living their lives and they don't have to come to the hospital for appointments. The CNSs make a mutual decision within a follow-up clinic appointment. Both parties have to be satisfied that they have no significant or outstanding concerns from a holistic needs assessment. They need to be aware of the red flag symptoms and feel confident that the patient will get in contact with the team if there is any concerns. All patients will have received an end of treatment summary, and myself will get in contact with them patients just to outline the red flags again, make sure they're happy to go ahead and have the contact details. The surveillance protocol has been ratified by the Pathway Board and a robust digital management system is in place. Urgent clinic slots are available to see this cohort of patients.
And I'm quite new to the team, but my responsibility now is with the newly diagnosed patients. So they'll come in and get their diagnosis in the clinic with the consultant and the CNS. And then I tend to wait a few days, they can process the information. And then I'll give them a call and see how they're coping after the news, and just see how we as a team can help them with the next steps. So that means between the 2 of us, we'll like support the patients at multiple points in the pathway where their needs might be slightly different. And now, where do we fit in, like, with the CNSs? So we share an office with the CNS, well, almost, we're like down the corridor from them. So that makes it easier for us all to support the patients in a holistic way. So the nurses can focus more on clinical concerns that patients might have, while me and Melissa will have the knowledge on like charity and community services to help with other concerns. So before our role was around, the CNSs had to do their own holistic needs assessments. And with all the other responsibilities that the CNSs have, the time wasn't there to dedicate to researching what services are available in the community. So I think that's good. We support the CNS in that way because we have the time, we can research what's out there and offer them services to patients. So we support each other.
We have some slides to show you detailing how valued the CNSs are by patients. But before we move on to that, we just wanted to say how much we value the CNSs. They do such excellent work. And without our CNSs, we definitely wouldn't have had the confidence to stand up here and talk today.
Definitely. Now, we've spoken about our role and what we think of the CNSs, but I think we've got some slides of like what patients think of the CNS. Yeah, there we go. So these are just some like messages that have been sent in that patients have written. Should I read them out? I can't read all the handwriting. I can give it a go. Dear Rachel, thank you so much for all your support over the past year during my, does that say PMP journey?
Yeah.
PMP journey. It's made such a big difference having a point of contact for all my many queries and concerns. Oh, you've such a warm and caring manner. You've made a very difficult time much easier. That's really lovely. Thanks, Bex. I always enjoy speaking with you. Thanks for doing this. You have an amazing talent of always making me feel better after I've spoken with you. I love your honesty. You're one of the most professional nurses I have met and so kind with it, and I'm lucky to have you as my nurse. Oh. I think I've got a couple more slides. I can't read them all, I'm sorry. I'll be up here all day. But yeah, some nice messages. Yeah. Oh, and then, yeah, some pictures of some of the CNS teams from around Greater Manchester. So I think I recognise some people from today. And then we will just leave you with this audio clip now. It's just some of, it's patients, again, telling us what they think of the CNS role. Thank you very much.
I come downstairs in the evening to get a drink, etc. And she's texted me sometimes about 10:30 at night just to let me know everything's all right, which makes a huge difference. She means a lot to me and to my family because obviously the whole of my family all know about Amanda and how amazing she is. I just think if everybody was like her, the world would be a fantastic place.
Hi everyone, this is the CNS team for Wigan, Wrightington and Lee. The following clips are a sample of patients that we asked to contribute to today's forum. We hope you enjoy them. So Harry, what does the colorectal specialist nurse role mean to you?
My experience of the colorectal nursing staff and oncology staff at Wigan and the treatment has been extremely positive. I have received the best care and support. The staff have been extremely caring, professional and kind.
So Glyn, tell me what a colorectal specialist nurse means to you.
Since my wife was diagnosed with cancer and had the stoma bag, they've been such a good help. They're always there at the end of the phone and we can't come to thank them anymore for what they've done for us. Thank you very much.
And they'll tell you that you can talk to them in a layman's term better than you talk to a surgeon. Patients are sort of and I'm not frightened of surgeons, but patients are generally a bit apprehensive when they're talking to surgeons. So my dealings with the likes of Carly and Deborah Broxton, and I had my operations at Christie's, the same at Christie's, was that they tell you more than the surgeon tells you, and they tell it in your terms.
With the help and support of the colorectal nurses, I don't think I would have got through. They're brilliant.
So I would say it's massive support. It's someone who can help with the anxiety when you go through your meetings. It's someone that you can ask questions to, and is support both for me and for my family. So it's something that is kind of definitely needed, and I suppose I've only really thought about how special it is since you've asked me, but it's definitely something that is like without it, having had the experience without it, it's definitely needed. So yeah, make sure you carry on.
Oh, well done. Well done. Well done. Do you ever get the feeling if you need something doing, just go and speak to Melissa and to Becky? And I always think it's really lovely when people share their stories of what inspired them to take up the role. So Amanda, thank you for sharing that, and well done. Your passion and your commitment really shines through. Follow that. I can't wait to hear from Nicola, actually, because this is a role that I don't think I'm particularly familiar with. So this is how the physiotherapists contribute to supportive oncologists. I'm really interested to hear this.
So thank you. Yeah, I'm a bit gutted that I'm following that. But thank you for the invitation to speak today. My name's Nicola. I'm a physio that works at the Christie. And I'm in a newly developed Macmillan-funded post as a specialist physio in supportive oncology. And that's what I'm going to talk about today. I'm going to talk sort of broadly about supportive oncology as a whole. But obviously I'm coming at it from a physio perspective. And I'm here really sort of presenting the work of and presenting on behalf of Dr. Richard Berman and the supportive care team at the Christie, who are really driving this work forward. And just related to terminology, supportive oncology is a phrase that's used interchangeably with supportive care through the UK. So you will see both terms through the session. So as has kind of already been mentioned today, we can't really discuss supportive oncology without thinking about the developments in cancer treatment that have happened over the past decades, and the fact that we're now in a position to progress and develop services for people who are living longer with cancer and increasingly with advanced disease is because of the work of everybody in increasing people's survival. And you can see some of these develops on the screen. You can see Dr. Berman standing very proudly in front of the proton beam machine at the Christie, and also one of the robots that was mentioned earlier. So I'm sure these numbers won't be new to you, but people now live nearly 6 times longer after their cancer diagnosis than was the case 40 years ago. And so more and more people are living with cancer. In the UK at the moment, that's over 3 million people. And that's expected to rise to nearly 5.5 million by 2040. And 130,000 people in the UK are living with treatable but incurable cancer. And we know that that's a group particularly with high need, so across emotional concerns and physical health needs. So the evidence suggests that people with treatable but incurable cancer struggle with fatigue, pain and anxiety, amongst other issues. So around 25% of people with cancer are living with the long-term consequences of that cancer and its treatment. And that's led to the development of emerging populations in the cancer population, which brings specific challenges in management. And, you know, this is almost a positive healthcare challenge because it's on the background of a lot of progress that has been made. So, as was mentioned earlier, metastatic cancer survivors is a term that was relatively unheard of until recently. And so now we're in a position to start to think about survivorship care for people with metastatic cancer. And that care must include thinking about the varied disease trajectories that people might be on through that survivorship, which might include periods of disease stability and remission, periods of needing more treatment, and predictable or potentially sudden transition into end-of-life care. Similarly, late effects in people with cancer is another new area. And late effects aren't any longer a consideration only for those who are cancer-free. We're now seeing patients experiencing late effects of one treatment whilst undergoing another treatment. And again, that brings new problems to address of how to manage late effects in someone who's undergoing a current treatment without affecting that treatment or affecting a choice of future treatment further down the line. And so Macmillan and Public Health England back in 2020 did some work on this, highlighting the situation that we're in, and you can see a quote from them on the screen, stating that the UK's health and social care services are not set up to meet the long-term needs of people with cancer. And we know that cancer patients have complex symptoms throughout the cancer continuum and can benefit from these being addressed independent of prognosis. We also know that palliative care teams can relieve complex symptoms, but those teams might be inaccessible depending on where the patient is in their journey. So it's led to a concern that traditional oncology and palliative care models don't serve the needs of the cancer population any longer, and actually we need something new and something additional to meet these needs. Which brings us to supportive oncology, which grew out of this need. Now, as I mentioned, supportive oncology used interchangeably with supportive care. Tend to prefer the term supportive oncology just as it can differentiate itself from the best supportive care terminology that's used towards end-of-life care. And you can see a definition up here from the UK Association of Supportive Care in Cancer. And you can see that there's a real emphasis on collaboration and team working across medical and non-medical specialities and spanning the entire spectrum of the disease. So it's really highlighting the breadth of issues that people with cancer face and the number of different professionalisms and perspectives that are needed to try and address those needs. There are some aims of supportive oncology, which you can see here, and this is across the whole pathway of care and across settings as well, so not just thinking about inpatient settings, but outpatient settings as well. So providing personalised and targeted treatments consistent with stage of disease, understanding that pain management, for example, in someone coming towards the end of their life would be very different to pain management in someone living with late effects of treatment. A focus on preserving and improving quality of life, so trying to keep people well as they go through their treatment and after their treatment, and protecting that function and ability to do what is important to them. Looking at affecting survival and the quality of that survival, and also preventing problems and de-escalating problems when they do arise to try and keep people on their treatment pathways or on their sort of follow-up pathways. Also looking at diagnosing and managing problems as they arise, which involves integrating with other specialities and services as needed. And again, this could be related to cancer and its treatment, but we also have a role in diagnosing and managing non-cancer problems and comorbidities that are having an interaction and impact on cancer-related issues. So more chronic and degenerative problems, things like COPD and arthritis, that might be having an impact on the patient's quality of life, but also their performance status, for example. There is building evidence for supportive oncology. You can see some references at the bottom of the screen. So we know that supportive oncology can improve symptom control and quality of life. It can reduce emergency room attendance. It can reduce hospital admissions and shorten the length of those admissions. Reduce chemo deferrals, so as we said, keeping people on their treatment. Reducing 30-day mortality after chemo. Improving overall survival and reducing healthcare-related costs. And this is done through collaborative expertise on a wide range of problems. So you can see a big list here. This isn't exhaustive, but you can see the range and the scope of what our patients face, but also what we can try and address in collaboration with others. I'll give you a bit of time to read through that. And obviously to try and address some of those problems and all of those problems, you need input from a range of specialities. Again, some of which you can see on the screen here. So we're trying to get patients in front of people with the right skills and the right knowledge to address their needs across the pathway, as we said. So you can see the specialities listed in yellow are the ones that we either have direct access to at the Christie or that we have relationships with elsewhere. And not everything's in yellow, so we don't have access to all of the specialities that we would like to at the moment. And there's widespread support for supportive oncology, and you can see some quotes on the screen from leaders in the field across the UK and Europe. There's also professional organisations related to supportive oncology. So you can see the Multinational Association of Supportive Care in Cancer is a body that develops management guidelines, it holds annual conferences, and they also publish the Supportive Care in Cancer Journal. The UK Association of Supportive Care in Cancer is newer. They are developing a website, it's just not quite finished yet, but you can see the Twitter/X handle on there if you're interested in following them. And again, it's a source of education, research and networking for people working in supportive care or supportive oncology. There are links with the national agenda, so supporting more innovative use of the workforce through development of dedicated teams available to manage problems. And several UK centres have developed rapid access supportive oncology clinics, which supports the Royal College of Physicians Transforming Outpatients initiative. So for example, at the Christie, we have daily supportive care clinics that are available for rapid access and the management of emergent and more chronic problems. And that is open to anybody, so across diagnoses, across prognoses, age, we kind of will see anybody. And at that clinic, we have our supportive oncology doctors, specialist nurses, physio, pharmacy, and we can also refer to other specialities as needed. We talk about supportive oncology services supporting early diagnosis, as I mentioned, so of problems and reducing burdens potentially on emergency and unplanned care. And supportive oncology has clear links with the National Allied Health Professional Strategy, which highlights the need to have patients have access to the right skills in the right place at the right time to meet their needs. There's also support for this in the current major conditions strategy, which has a specific section on living well with and beyond cancer, and highlights the importance of understanding how to improve quality of life for patients living with the consequences of cancer and its treatment. So think about how we're implementing all of this locally. The Christie Supportive Care Team changed its name from the Palliative Care Team several years ago, and that was to try and remove some barriers to access and remove that association with only end-of-life care. And it's made easier to refer patients earlier in their journey and at different stages of the disease and the pathway, and allows for that increase in scope with provision of care across the whole cancer continuum. And as I mentioned, we have those daily supportive care clinics Monday to Friday. And obviously, expanding and developing services in the current healthcare climate requires innovation. So these are some of the ways that leaders in supportive oncology are innovating to try and deliver their services. I'm going to go through some of them. So we have supportive oncology advanced practitioners. So at the Christie, we have supportive oncology pharmacists and a supportive oncology physio, that's me. And as well as providing our expertise into the team, so into team meetings and case discussions and just the working of the team, we also carry our own caseload that we're having a direct impact on. From a physio perspective, I mainly focus on the non-pharmacological management of symptoms. So that is a broad range of things, so pain management, general deconditioning, musculoskeletal dysfunction, chemo-induced peripheral neuropathy, breathlessness, fatigue. I mean, the list goes on, it's quite broad. And I also refer on to other specialities, so occupational therapy, and also other subspecialities of physio, so hydrotherapy, community physio, and importantly, pelvic health physiotherapists, which specialise in the management of continence issues. We're looking at developing future roles, sort of allied health professional roles within our team as well, so things like occupational therapy and dietetics, which we don't have specific to supportive oncology at the moment. Specific fellowships in supportive oncology are in development with the Royal College of Physicians. train people with the skills that they need to manage the broad range of supportive oncology problems. And the idea is to almost build an army of people who can look after these patients. It's going to start with doctors, but there's a view for it to expand into non-medics further down the line. Broadening the scope of palliative care, I mentioned earlier, so looking at palliative care teams also being involved in survivorship care and management of symptoms in people with longer prognoses as well. And very recently, the Christie have established a supportive oncology directorate. I think this is the first of its kind. And the idea is to really integrate services that can support our cancer patients, bringing them together within a governance structure with a specific strategy, and trying to improve and develop across the services that we deliver. You can see some components of the directorate there. And just to mention the multidisciplinary team meeting that we have, it was twice a month, but now it's going to weekly because of the demand. And complex cases can be brought there with discussion from a huge range of people that you would expect from an MDT, including external services. And so we can try and kind of put all our heads together and make a plan to try and meet people's needs. And just say this is the overarching goal. So I'm sure we all drive for and have a focus of what the patient needs at heart, but we're looking to make that pan-cancer, so trying to overcome some barriers that have been traditionally sort of putting people in silos and have people able to access the help they need at the time they need it. Thank you.
Well done, thank you. I think what we've heard here is the importance of the whole team in making sure that we keep patients at the front and centre of their cancer diagnosis journey. So well done, everybody. I thought you were brilliant. I think we're going to questions now. There must be loads of questions. Thank you. I think we have somebody over there as well.
Thank you. My question was just about the robot. So when you go up a model, and up a model again, £1.5 million-ish is a lot of money to spend. What happens to the previous model? Is it recycled? Do you get money? How does that work? Because obviously you want to keep up with technology. I'm just curious as to how that works.
I've heard Christie's puts it on eBay.
Say that. Basically, what we do is some of it we use it for training. Some of it the company takes back, and then they sort of reduce the price of the newer one. It's like buying your car, you know, same as what you do.
I think we have to.
Thanks, Shaker. Great presentation. Just a question for you. What's your experience with robotics operating on patients who had TNT versus long-course chemoradiation? Easy, difficult, similar experience to long-course chemoradiation? That's one part of the question. Second is, sorry about that, don't want to have to come back all the way to me again. You know the Scottish have got their own national training program now for training the registrar to be able to be robotically competent when they become consultant. We know there's something similar starting in England as well. So just shed some light on that, where we are with that, and when it's going to kickstart, and how quickly the GM trainees can get benefited. Thank you.
Good questions. Second one is a good question to ask. The first one, I think, as I mentioned, if the duration between radiotherapy and surgery is longer, it is technically challenging. It doesn't matter whether you do it open, laparoscopic, robotic. We've tried all three. It is difficult. So earlier we can get them operated, and that may be the reason why the results are, what Claire showed. Because it fractures. The tumor fractures, and probably there are also a group of patients who are poor prognostic group. But certainly it makes this surgery difficult. Going back to the training, which is a very important question, which I think we are trying to address it. Basically, there was a pilot in the Northeast where, because they had a training center in the NSTC, Newcastle Training Center, that was like a hub, and they had systems in the Northeast where each hospital, the 30 hours of simulation training could be done by the trainees. And the same model is what is being used in Scotland. But 2 Royal Colleges have joined up, and the same as what is being used. There are about 12 systems in Scotland, and it is not yet started, but that is a plan. And similar model is what we are looking at in the Northwest. Just wait, I think there's a meeting planned this week or early next week, so you probably will hear from Emma Davis about how it is going to be implemented. But there are 3, London, Birmingham, and Northwest have been identified as centers where there's a need to push for this robotic training for the trainees.
You've got a question here.
Thank you. Just a question for Nicola, please. Just really intrigued about the supportive care team at the Christie there, and the change from the name from the palliative care team to supportive care. I know in other trusts, obviously, the palliative care teams are often called palliative and supportive care teams, but like half of their caseload approximately are cancer patients perhaps, and the other half are on non-cancer patients. So I'm just wondering if there's been any sort of discussions with your colleagues in other trusts about how they might go, doing a similar approach in terms of what you've been doing at the Christie and how that would work between cancer and non-cancer patients in those other trusts.
Good question. I'm just thinking about people that we've linked in with and other models that we know exist, and I think a lot of them are cancer centres. I know, for example, Clatterbridge over in Liverpool, very strongly, although they deliver supportive care, they've kept their palliative care name because there's kind of a bit of a different perspective on, they say they're still palliating the symptoms and things. So I'm not sure how it plays out with non-cancer and cancer. I guess there's a question about resource, isn't there, as well? Because already sitting within a tertiary cancer centre, thinking about broadening the cases that you can see from palliative care to supportive care, there's a resource implication. So I guess looking at that in a trust that has lots of different diagnoses and different pathways, it could be quite difficult. So I'm not too sure about that. Apologies.
So I have 2 questions. So I've got one for Serka, and then I've got one for the rest of the panel. So I was talking to a newly qualified surgeon in a different specialty a couple of weeks ago, and we were talking about robots, and he wanted a robot, and I said, it's really expensive and value for money and doesn't really do anything. And he came straight back at me and said, but it absolutely eliminates the margin for error as a newly qualified surgeon. And I thought that was absolutely phenomenal. And then I thought, well, actually, are we de-skilling our newly qualified surgeons? So are robots a good thing, or?
I think it's a good question. I don't think you're going to de-skill. What used to happen is when we take the gallbladder removal as an operation, we used to do it open. And when laparoscopic surgery came, the surgeons were trained to do them laparoscopically, and there was not much to do it open. But then you always find the number of open operations is less. So as technology advances, as we diagnose diseases early, we use these new tools to get better benefit. But the benefit is only marginal, Mary. This is a thing which, it is not like the be-on or end-all. It's not going to replace surgeons. It's not an automatic machine. It is always under the control of the person who uses it. And it makes what you do is the same. It makes the job a bit easier. Benefit for the patient, marginal. But just to touch upon a difficult topic here, if you look at what the oncologist use for chemotherapy, the price of what a robot is much, much less. Because the drugs which Mike uses is probably about 10,000, 20,000 pounds per week. When you compare that to a robot, it is much less. Well, that shouldn't be the argument, but what I'm trying to get at is there is benefit in using newer technologies. It's like going back to the car sort of a scenario as an example. The cars, what you have, are much safer. It benefits the passenger, it benefits the people who are around. So similarly, having a robot is beneficial. But I think it needs to be evidence-based. And in that way, the NHS is very good at it. Unlike if you go to insurance-based healthcare like the US, It is a different system. It is all over the place. And that is one of the reasons why the healthcare system, some countries are not sustainable.
Thank you. And my second question to the panel is I think cancer services can be one of the most rewarding and difficult specialties to work in. So how do you look after yourselves and each other?
Don't go to the pub, Seika, but I think it's your team that you work with, and it's definitely being able to speak to your team. And if you've had a particularly difficult diagnosis, or, you know, because everybody's got their own loved ones, and you can speak to your team and say, God, this is really sad, and you can talk about it. And it's about the positives that you can bring for the person and working together to find a positive outcome, even in the most negative situations.
Yeah, I think that's the same for myself, and also going to the gym and looking after yourself and eating healthy. That is, you know, that's vital for my well-being. So I do try to put that first as well.
Anybody else?
We have, like, I've not done my first one yet, but we have supervision, which is like something that you do with like different, it's like with CNSs and all different people in the team, but it's people not in your own team, just in case you feel weird talking about stuff in front of them. So that's good, you get to open up and chat when things are difficult. Yeah.
Going like that, aren't they, with the microphone inside? Yeah. Yeah.
So yeah, when we went on a Breaking Bad news course a year or two ago with the team at Christie, and what our teacher told us was that she wasn't allowed to do that course or do her job if she didn't regularly audit and document that she did a level 2 supervision. Level 2 supervision is helpful, but it's difficult for busy CNSs to always get to. And it should be a safe space where we can talk about some of the things that really affect you in what is sometimes a very difficult job psychologically. But the other thing that's helpful is having an environment where you can talk to colleagues in confidence and privately. And in my experience over the last sort of 10, 15 years, those environments are disappearing. Office space is very hard to come by in acute trusts. And I think it is a mistake to neglect those areas, because being able to have a confidential conversation with a colleague, but also with a patient in a difficult situation, is supremely important. And I think we should all be lobbying for those environments to be maintained.
So we'll look forward to the next Colorectal Award, where you've got Roger Spencer to give you a bit of a private room and space to have those very important conversations. We'll look forward to that. Okay, thank you very much. I think I'm handing over now to Roger to judge the posters, give out awards and close the door. Thank you.
Thanks very much, Mary, and thanks very much, team, for that absolutely barnstorming final session. It was a challenge, wasn't it, to follow that kind of vox pop from the patients. But Nicola did a terrific job, and it's great to see best supportive care mean something. I do worry sometimes in MDTs that it doesn't mean a lot. Apart from not my job anymore. That was absolutely brilliant. So I can inform you that the votes have now been counted and verified. If you're watching on catch-up, please don't vote, because your vote won't count and you may still be charged. So here's the result in no particular order. So the winner, I'm delighted to announce, is Keely Agnew for colorectal specialist nurse at NCA. I had nothing to do with it, for the colorectal cancer MDT reform from the Salford Clinical Nurse Specialist perspective. So congratulations, Keely and the NCA team. Is Keely here? Oh. Congratulations. Well done. So some closing thoughts from me. I was tickled to hear that Seika's discussion about, well, the oncologists spend more money than us, so we should have more robots. It reminded me, I don't know why, but it reminded me of when I was on my elective in Brazil. I was reading a headline in the O Globo newspaper in Brazil that said, Brazil's corrupt, but it's okay. It's not as corrupt as Argentina. It just occurred to me then, really. I've got some thank yous to do. I'd like to thank Norgine and Sergis again for the sponsorship, generous sponsorship that's enabled us to have the meeting today and have it in what's been a fantastic facility. I'd like to thank the Life Centre for having us, and it's just been fantastic, flawless, really. But of course, I need to thank the GM Cancer Academy for supporting with the logistics of the event. And that reminded me, I was having a conversation just before about when I was a wannabe rock star when I was younger, and somebody said, what was your job in the band? I said, well, I was a singer. Why did you do that? Well, it was the maximum glory for the minimum effort. Why would you not want to do that? So, and that's what I've got today, really. I've had lots and lots of time to bend your ears and tell you some odd things here and there. And I've done none of the work at all. So it doesn't get much better than that. But it does behove me now to thank Tilly, Sam, Jess and Ellen from the GM Cancer Academy team for all hard work. If you're still here, stand up, please, and we'll all give you a thunderous round of applause. And it would have been immodest for Rachel to have written this on here, given that she's written these crib notes for me. But we need to give a massive round of applause to Rachel Allen, who's really helped pull all this together, put an awful lot of work in, as you'll all know. Rachel, stand up. We'll give you a round of applause. And thank you also, of course, to all the colorectal patients who've trusted us to look after them, but have also, even better than that, trusted us with some of their most intimate thoughts and expressions of that in the art, which has helped really give us an amazing context for the day today. And I've been really touched by reading the poetry and looking at some of the images that we've had. We tried very hard to make this a really inclusive event, and also something that captures something of all the elements of the system that help support the management, the diagnosis and the treatment for colorectal cancer. If you have any thoughts about how the day could be improved, what we might include next year, something that you think may have been looked over or left out, please let us know. We tried to make every presentation as concise as possible, and the presenters have done amazing jobs in squashing quite complex subjects into a small number of slides, and keeping everybody engaged, as evidenced by so many people still being here today, despite the beautiful weather. Pleased to report that the meeting is CPD accredited, so you'll be able to get CPD points for being here today, and those will be shared with you in the next 2 weeks. So the final words for today are going to come again from a patient, and we're going to close with another poem, and this is from Maggie Bell, and it's called Keep Moving. One day after many years of crying empty, lonely tears, the time's come to realise what really comes as no surprise. It's time to change, time to grow, acknowledge what you already know. A journey forwards is beckoning you, letting you know what you have to do. Keep moving towards the light. Leave behind the darkness, the night. Leave the negativity and the mind games, the put-downs and the calling of names. Know your worth and know who you are. Shine again like a golden star. Thank you very much.